Hello, everyone. Welcome. We will get started here momentarily. Welcome to the webinar. We'll get started here in just a moment. All right, looks like everyone's getting to join here in the webinar. Just wanted to say hello. Thank you for joining us today. Welcome to the 2024 PQA Quality Forum Webinar. My name is Amanda Ryan. I'm the Director of Education here at PQA, and I will be your host for the webinar today. Our topic is payer pharmacy partnerships to support sustainable community pharmacy patient care programs. Before we get started here, I'd like to walk you through our usual housekeeping items. First, please do submit your questions to us. You can do that throughout the presentation today. It's great to see questions come in as we're having the presentations. Allows us to organize our thoughts for you, and we will address your question during the Q&A portion of today's webinar. Also, we will have a recording available to PQA members along with a copy of this slide deck, and that will be in the Member Resources Library section of the PQA website in about a week from today. In addition to that, we will post a recording of today's webinar on our YouTube channel. And then finally, I'd like to encourage you, as you exit the webinar today, you'll see a survey populate. It takes you about 1 minute to complete that, and we really do appreciate your feedback to help inform our future programming. And with that, it is my pleasure now to introduce today's speakers to you. First, we have Chris Daly, who is a clinical associate professor in the Division of Outcomes and Practice Advancement at the University of Buffalo School of Pharmacy and Pharmaceutical Sciences. Also with us is Heather Gibson, who is a director of performance measurement here at PQA. And finally, we also have Ben Shirley, who is a senior director of performance measurement at PQA. Thanks to all three of you for being here with us today. And with that, I will turn the floor over to Ben.
Great. Thanks, Amanda. Super excited to have everyone on and talk a little bit about this exciting work. Before we get too far into it, I do want to make sure we acknowledge the funders that made this work possible. So Chris Daly does declare grant funding from the Community Pharmacy Foundation. He is also a National Task Force member of the Academia Community Transformation, or ACT, Pharmacy Collaborative. And while we're there, PQA also has some grant funding to declare from the Community Pharmacy Foundation, as well as grant funding from the Kroger Company. And so before we get to the main event here, I can very briefly set the stage. You know, as many of us are aware, the importance of pharmacists and pharmacies as members of a broader care team has very much been growing post-COVID, and it will continue to grow into the future. Payers and others are continuing to realize the extent to which pharmacies really can support and contribute to healthy outcomes by offering services and driving quality rather than sort of serving as the traditional dispensing outpost, maybe into which they've been siloed in the past. But with that sort of expansion of scope and responsibility comes an entry into the sprawling, confusing world of value-based payment and agreements, a world that health plans and managed care organizations and ACOs have been navigating for a while, but pharmacies are sort of the new kids on the block here, and they face some unique barriers, especially around measurement, thus PQA's focus. There really is not a standardized set of pharmacy measures that are endorsed in a consensus-based manner, and available for use and able to ensure consistent and fair measurement. And that really creates a problem in an ecosystem where fair and accurate measurement of important outcomes is the cornerstone of value-based payment, which it very much is. So that sort of lack of measures creates a substantial problem to having scalable and successful VBAs between pharmacies and payers. And further than that, this stuff isn't simple. It's not self-explanatory. There's no easy roadmap for entering into VBAs if you're an independent pharmacy or a chain pharmacy or any kind of pharmacy. It's a complex space. It doesn't have a top-down regulatory program that comes with a rule book the way that MIPS, the merit-based incentive payment system, which is Medicare's sort of original individual provider level quality program, or say the Medicare Shared Savings Program on the ACO side. There is no top-down program explaining how payers and pharmacies should engage in VBAs. So it can be hard to know how to get started. Thankfully, there are some resources available to help pharmacies get off the ground. And that dovetails, I think, and sets the table very nicely for Chris. So I will go ahead and pass it off to him.
Thank you so much, Ben. Very excited to be here. Thank you for the opportunity to speak and be part of this webinar. Very important to the work here, and as Ben has mentioned, this is a growing area, but an area that we're seeing a transformational change in community pharmacy. So, I've been very fortunate in my role here at the University of Buffalo to really be able to develop these unique collaborations and really highlight how community pharmacy that has always been in public health and always has been a fixture within the communities, but how does it come together in an organized way to really be effective at a larger scale to impact change? And we're here to talk about that and how that change is impacting overall. So to date, what we're monitoring and what we're looking at is community pharmacy patient care programs have demonstrated positive impacts, implementing practice transformation efforts, and through the guise of clinical integration, or another way to say that is single signatory. So in individual pharmacies coming under one umbrella in order to participate in a program, those are growing. And to date, specifically within one movement that we looked at, CPESN, Community Pharmacy Enhanced Service Network, there's over 100 programs to date that we're looking at. Our collaborative ACT, which stands for Academic Community Transformation Pharmacy Collaborative, brings together different researchers, but also active members of these various networks to really look at the larger scope of how does this fit into practice? How are we teaching our students? But more importantly, how are these services impacting patients and really coming to market overall? So what we set out to do here is really encapsulate the practice transformation, but we know there's really two sides to that. There's pharmacy reimbursement changes that are going on at the same time. And how does all this come together? What are those motivating forces and factors that pharmacies are able to come together to really look at those next steps? And in our project, go ahead and advance slide. Really, the main goal here was to ask those. We wanted to identify best practices for implementing patient care programs in collaboration with program facilitators. And this was done within the CPESN networks. So we had a pool of about 40 individuals. They're termed managing network facilitators, but essentially they're responsible for the communications, the facilitation, the implementation of these programs. And through mixed methods and our implementation science, really wanted to collect what are these principles? What are these activities that we're doing that sets up the network for success? And we were able to work through that in our program and really found some robust results. So with that, these program facilitators, or also termed managing network facilitators, completed a survey and a semi-structured interview. And of the 14, we had a range of experience. Some were part of, a more mature network, I would call it, and others are, part of an earlier network. But we are, talking about individuals who spend a significant amount of time engaging with health plans, payers, departments of health, and really maintain these programs as well. They're multifaceted, they have many other responsibilities, but they do spend a significant amount of time managing that. Beyond that, when we're looking at what are these networks, what are those characteristics of these 14, an average network size of about 120 pharmacies, cumulative programs to the date of this, about dating back a year ago, was 7, and the average number of programs managed at a time would be 3. And we had a wide range of payer types, but really the take-home point there is there's a variety, right? There's just not one program that is looked at. There's a variety there as well. So when we were looking at this, there were some major themes that were identified. And within this, we're going to be to talking about the highlighted ones, the ones that are most significant. But in this, we did see there were best practices around engaging, where to start, how to health plans, payers, find networks, how do networks find payers, what is that collaboration about, and what does that look like? Well, what that looks like when it depended on a program or intervention is of both sides. How do they come together to look through that? Contract setup, of course, was talked about. A lot of that is proprietary and specific to the situation and entities, but it is something that is an important step and one that is worked through. Program collaboration, so this is ongoing, but even more important would be implementation training. So setting up the pharmacies for success, being able to cover what are those goals and objectives of the program and how are they best executed throughout the timeline of the entirety of the project. Very important to any project would be the outcomes assessment. And then, of course, data collection and what are some of those tools that are looked at there. So within engagement, one of the leadership and individuals was asking, well, it's not what you know, it's who you know. And that's very, very true in many of the things we do overall. So these individuals bringing together the different aggregation of pharmacies under the network, the different health plans and payers that have specific responsibilities to their fiduciaries as well. And really, in some of these initial conversations, it's very important to be open-ended and ask some questions about, well, what is the purpose? What value would a network of community pharmacies, within a certain geographical region, within a certain patient population, how does that come about? And it may not be, a situation where it happens right away. There might be some lag or timeline before things were to be in place. So sometimes these meetings can be spontaneous. They can be at associations, pharmacy organizations, departments of health, local important meetings. So really there wasn't one, strategy or one way to look into this, but really beginning those conversations was what many individuals agreed with, and having ongoing productive conversations that bring value to both sides really are important in that engagement. And being able to do that over time, definitely makes these conversations more efficient, but also, be able to understand, from both sides and be able to balance, what those goals may be. The other very important takeaway here was the program and intervention design, right? And really what was discussed and brought forward really in all of the conversations was it is a collaborative process. It's one that's iterative, it's organic, and it starts with identifying, potentially the payer's needs, the network scope. Is this something that can be scalable? The number of pharmacies in the specific area. That's really going to be dependent on the different type of outcome looking at or patient measure that is desired. Pharmacy resources, is this an intensive intervention? Is this one that requires additional documentation, additional equipment, additional training? And then how does that outline over the target population, which is really, really important to outline this as well. So when determining this, some of those takeaways are, looking at those combination goals and what is actually feasible within the pharmacy and all those involved. And the managing network facilitators or program facilitators are the ones that balance those two directives. And kind of getting at before what we've looked at many times with these or with these programs is how do we realize that pharmacies are able to impact certain areas of need. And it may be one of those where a conversation may be needed, but down the road or in a more timely situation, there's able to be, re-engagement to look at as well. So a lot of times having these initial conversations are very important and would be encouraged, and that may lead to future collaboration depending on the outcome and desired. Implementation training. So we're getting to that, part 5 here. Very vital component. How it's done really is an important step for the success of these programs. And it happens in preparing before the patient care service is actually implemented within the program. So components are generally required at the start, but equally important is having ongoing communication and training sessions to make sure that if there's changes or there's specific things that are needed, that is able to be realized overall. And this is done in collaboration with both the pharmacy network, the program facilitator, and the payer. And some of those quotes, some of those qualitative feedback that came back is best practices include workflow inclusivity within the team, just not one person's role, so a team effect. And we especially saw that within social needs screenings and training different pharmacy personnel to be community health workers. Beyond that, what seems to be the most help is pairing certain network pharmacies with other pharmacies that are comparable, may have similar pharmacy management systems so they can communicate best practices, more or less like a peer-to-peer intervention there as well. And that's one of the great advantages of clinical integration. Outcomes assessment, how do we measure? How do we know what we're doing works and is able to be expanded and sustained? Well, it includes both the program data and also pharmacy experience. How are things being implemented? What are some of those patient success stories that are coming out that may not fit neatly into an outcomes type measurement? And that information is being collected on a regular basis. They should have continued assessment throughout the program, and that feedback should be communicated both to the pharmacies and to the payers in a bi-directional way as well. And being able to do this, have internal network assessment is also very important. So this is done within the network, within its own program. Sometimes that's termed quality assurance. And then, specific program evaluations, we included some references for you of where there's ongoing ones. This table just goes over some example fields that you would expect to see in outcomes type data. So for newer contracts, you're generally exchanging lists of pharmacy locations, population demographics, a list of existing patient care services and programs, because we know within clinical integration, there's a inherent quality standard that is brought together. So there's a minimum quality standard that needs to exist, and that's usually disclosed up front. With existing or ongoing contracts, you're looking at program adoption, utilization rates, intervention details. That could be mostly, quantitative, but also qualitative. That gets to the internal assessment, and then patient outcomes, and that could be facilitated through a variety of methods as well. And from a quality assurance point of view, this is something that is required of these networks, which was really great to hear, really great to see. And pharmacies are continuously looking at this from a compliance point of view. Are the pharmacies meeting their metrics to be able to stay in? But also within the program, are there quality interventions? Are the clinical outcomes being accomplished associated with the goals that were established early on? So in collaboration, between pharmacy networks and payers, we're seeing this not only expand, but grow, which is very, very exciting. And one of the outputs of our work here in working with these program facilitators is to be able to build a resource guide that provides high-level framework from a multi-stakeholder point of view, outlining best practices for partnerships between payers and clinically integrated networks of community pharmacies. And we're excited to be able to bring this in association with PQA in the very near future. All right, at this time, I would like to bring on Heather, and the slides are yours, Heather. Thank you.
Thanks so much, Chris. All right, well, we just heard from Chris how pharmacy interest in offering innovative services and engaging in VBAs with payers is really growing. And he walked through his team's efforts on developing a resource guide to provide a framework outlining best practices for partnerships between payers and pharmacies. And part of the keys to success within VBAs are really these standardized quality measures. VBAs between payers and pharmacies are really critical to pharmacies' ability to demonstrate their value and be compensated for the services and care provided, as well as to sustainably support improved patient outcomes. However, successful VBAs really do hinge on the ability to fairly and accurately capture the quality of services provided by pharmacies. And really to date, and Ben alluded to this earlier, the industry has suffered from a lack of valid and standardized consensus-based quality measures that can be used to objectively assess quality within the context of payer pharmacy VBAs. Traditionally, these arrangements have incorporated the health plan level measures that I'm sure we are all very familiar with. However, these measures have not been specified or tested at the pharmacy level of analysis. PQA endorsed its first pharmacy measure in 2013, which was primary medication non-adherence. And since then, we've added 5 additional quality measures to our measure manual, including 1 composite adherence measure. There is more work to be done, though, really to increase the availability and use of these measures. And to address this need for more standardized measures, in 2021, PQA hosted a series of summit meetings convening over 50 thought leaders, including those from pharmacy, other providers, payer, employer, technology vendor, and patient communities to identify and prioritize measure concepts aligned with these innovative pharmacy services. And this series resulted in A1C and blood pressure improvement and control measure concepts being consistently highly prioritized against a list of other measure concepts for full measure development based on the criteria for importance, feasibility, and usability. And the measure concepts that were included in our pilot, again, were A1C control, which was defined as greater than or equal to, or less than or equal to 9%. A1C improvement, which was defined as a 1% or more reduction in reaching control. Blood pressure control, which was defined as less than 140 over 90. And then blood pressure improvement, which was measured by a 10 millimeters of mercury or more improvement in systolic blood pressure, or by reaching that definition of control. And so working off that input from the summit, PQA secured funding, including a grant from CPF to conduct pharmacy measure use pilots related to the 4 measure concepts that were identified as being high priority for pharmacy measure development. And this project engaged payers, community pharmacies, technology vendors to pilot these 4 pharmacy measure concepts within VBAs so that we can assess the feasibility of data capture, reporting, and improvement towards evidence-based biomarker goals. Our approach to this work really falls within 4 buckets: use, validate, document, and refine. We're engaging with we did engage with 2 pairs of payers and their pharmacy networks to use the measures within their VBAs. And we validated the measure rates through a process that I'll speak to on the next slide. And we also documented the lessons learned from the pilots, both from the payer and the pharmacy perspectives regarding the benefits, challenges, and promising practices associated with using these measures. And in the end, we took those learnings. We may revise the measure specifications based on those learnings as needed so that we can add any additional clarity or further standardize them. And so really when it comes to our measure validation process for this pilot, it was really important to validate the measure results so that we can ensure the accurate implementation and calculation of the measure rates, not only so that we could be confident in the measure results, but so we could also identify opportunities to further clarify and standardize our measure specifications. And so to start the process off, we provided our measure specifications and the value sets to our partners for use. Our partners then used this information to calculate the measure concepts, and they also transmitted some raw data to PQA. So in addition to their results, which they filled out a results template for us, we also got the raw data. So we used that raw data to calculate the measure rates independently. And then we did a comparison of our measure rates versus our participant calculated measure rates. And we identified any areas where there were discrepancies. And so then we worked with our partners in an iterative process, really to resolve and reconcile those differences. And once those were resolved, our participants would rerun the measures, fixing whatever code, and then they would transmit the results to us. Again, we would double check and hopefully, achieve 100% agreement. And so related to some pilot learnings, specifically to program development, one of the most inspiring learnings I think that we've captured is that there was really strong interest from pharmacies and payers to participate within the pilot. And we saw a total of 32 respondents to the RFI that we put out for a total of 4 spots. And the folks that submitted their interests were incredibly passionate about innovative pharmacy services, providing more and better care to patients. And we also heard from pharmacies and payers that they really do want to partner and they want to establish these relationships, though, not all really knew how to do so. Which really highlights the importance of Chris and his team's work to develop a resource guide. Because of the timeline constraints of this particular pilot, we did have to select partners that already had some sort of pre-existing relationship, because those contracting timelines, as we found, can be very, very extensive. And so because of that, we learned that the contracting process should really be initiated as early as possible prior to the anticipated start of your activities. One thing we didn't anticipate, but was a really great learning, was that competing business requirements can divert resources at times. But it was really great to see that even when this happens, the pharmacies that are on the ground are still really doing that work to provide services to patients. And so even though there's some disruption in the background of things, the patient really never sees that. And so that was very encouraging for us to see. Related to data exchange, we also learned quite a bit about this as well, related to the use and calculation of the A1C and blood pressure improvement and control measures. First, the measures use prescription claims, medical claims, and lab values are feasible within payer pharmacy VBAs, which was really nice to learn. However, at this time, not all organizations have consistent access to those discrete A1C or blood pressure values. Traditionally, this information has been captured in ranges using those CPT codes. And so pharmacy systems have been built out in order to report those ranges. We can get there though. We've seen that it's possible to collect, record, and transmit discrete data. We also saw that the consistent calculation of our measure classifications can be challenging, which really just highlighted for us some areas within the specs that can be further clarified and standardized. And so we're working to do that. And also during the pilot, one of our partners saw a disruption within data exchange due to some unanticipated technology challenges that really impacted other areas of their business outside of this pilot. But, even though there was some flexibility needed there, and our partner in this case, they did a really great job with working with their pharmacies to ensure that there was no disruption to patients. Again, that focus being on making sure that the patients don't see any differences in their care and they're able to get their services. And all the data was able to be transmitted once those technology issues were resolved. And so we were able to move forward with the pilot, and that was really cool to see live and happening. We also calculated the pharmacy impact. And so we aggregated rates across MPIs within both pharmacy participant organizations. And we showed that there was an improvement from baseline to endpoint across all of our reportable measures. And so these are measures with which we had enough data to report on. Notably, the BP improvement in measures, unfortunately, were not able to be calculated. And that's because we noticed, as I said before in the prior slide, there was a challenge in transmitting those discrete blood pressure values. And so while we saw some of those come through, there weren't a whole lot, but it can be done. And so it's very promising for the future. And so this improvement from baseline to endpoint that we do see here on the screen really does highlight the influence of pharmacies on these important measure concepts, which really align with the biomarker measures included within the Centers for Medicare and Medicaid Services Universal Foundation, as well as critical payer programs like the Medicare Star Ratings. And while there's still opportunity for improvement across all of the measure rates within this pilot, the impact of those pharmacy payer VBAs, it shows that we can really achieve a lot in improving patient health, and, measure performance is really encouraging. So some future directions for us, we did yesterday, if you didn't see it, we published a full report on this pilot on our website. So I really do encourage you guys to go and check that out. We're also going to continue to collaborate with University of Buffalo and Chris to disseminate their resource guide that they're producing once that's ready. So we're excited to see what that looks like and share that with you all. We also have executed 3 new pharmacy measure pilots focused on adult immunizations. And so we're in the process of that right now. We're in our baseline measurement phase where we're validating data, which is really exciting. And so we're looking forward to documenting and disseminating any of the lessons learned that come from that pilot as well. And then these were some of our references that we had on the slide earlier. And I'm going to pass it over to Ben to facilitate some Q&A.
Lovely. Well, thank you very much, both of you. Fantastic presentation as usual. So everyone, please do feel free to submit your questions using the question and answer feature in Zoom. Those do come through on our side so that we can triage them. And we can start with the first question that came in. Chris, someone thanked you for the helpful info and noted that they are especially interested in the resource manual. So will that be publicly available, or would members have to request it specifically? Also, is there any idea around timing and when that might be available?
Great line of questions. Thank you for that. Yes, we are, very excited to, come to the end of this project, which encapsulates all of these best practices that we put together in one resource guide to be able to be disseminated. Our goal is a multi-stakeholder approach. So we feel that we've made it in a way that would bring value to many different settings and really be a starting point for conversations to bring different entities together. So as of this webinar, it is in production. So we're getting the finalized approach. And then as far as your question about publicly available, this will be available at minimally on the Community Pharmacy Foundation website at a future time and location. And I know we've been partnering with an excellent partner like PQA to continue the collaboration. And I do see joint continued collaboration on this as well. So I think that there will be multiple opportunities to be able to utilize this resource guide that will be publicly available. I do want to highlight as well as I do believe this is a starting point. So if individuals are looking to, maybe, have this interpreted or connected with local individuals that would be, a clinically integrated network locally as well, please feel free to reach out to me and I would be able to connect you with the right party.
Fantastic. Thanks so much, Chris. And we do have another question. This one I'll turf back to you, Heather. It looks like a participant or two may have missed what you said couldn't be measured for pharmacy measure impact. Was that blood pressure control due to data issues, or would you mind just running through that bit again?
Yeah, so that was blood pressure improvement. And so for the improvement measures, because we're looking at a very specific amount of improvement, greater than or equal to 10 millimeters of mercury in systolic blood pressure, we do need those discrete data in order to show that improvement. So we need an actual value versus a range. And so as I mentioned, right now, current systems are used to and are set up to report back those ranges, those CPT codes that I think we're all very familiar with when it comes to blood pressure. So we didn't get a lot of those discrete fields coming through. Something else that was noted by our partners is that when it comes to lab values like A1C, most health plans are already very well integrated with those lab organizations. So they're able to get that data fairly easily, which is why we were able to do and calculate the A1C improvement measures. However, for blood pressure improvement, that is more of a clinical marker and something that's transmitted through either the EHR or within the pharmacy systems. But again, most of those systems are used to those ranges, and so they're not set up for those discrete fields. But we know it's they're able to do it. Some are. I know within Flip the Pharmacy, they had an effort with blood pressures, and they were able to get some discrete fields when it came to those blood pressure values. So it's just about, really implementing the measures and updating our system so that we can capture more granular data.
Perfect. Well, thank you for that one. And the next question coming in is, would you mind, and I think this might be for you, Chris, we've been using the word network a lot. Can we precisely define what exactly a network means in this context?
Yes, Ben, great question. I can't provide a legal definition. I would encourage you to seek legal advice if you're looking for that in depth. But what we're getting at here with a network, and I've used the specific term clinical integration, is these are movements or really two major parts. There's governance, so there's a single signatory. So you as an entity, X health plan, X payer, X Department of Health, can go to one area or not individual, but an entity to be able to bring together multiple pharmacies, right? So the obvious examples are the corporate models that are designed this way overall. But really, this movement has brought together also independent pharmacies that are able to come together in a larger group to be able to do that. The other important concept here with clinical integration is a culture of excellence and quality, right? It's just not saying that, hey, you're together and you're able to still operate independently, but how do you buy into that culture of excellence? How do you self-evaluate for quality? And how do you participate in a way that is able to be expanded and sustained on overall? So those are really two key components in what we define as a network here. And we're seeing this now for multiple years, specifically with the CPSN, but other movements as well. Thanks for the question.
Perfect. Thank you so much, Chris. For our next question, Heather, circling back to you, with respect to the blood pressure control measure, did you measure BP going from uncontrolled or out of range to controlled? Was it sort of having no blood pressure data at all to getting some data? Can you speak a little bit more to the spec of exactly how the blood pressure control worked?
Yeah, absolutely. So for our blood pressure control measure, that one, we didn't just include individuals who were uncontrolled at the beginning of the year. That actually was a focus of blood pressure improvement. It was making sure that folks were out of control of their index value and then getting to control. But for the blood pressure control measure, we were really just identifying individuals who had prescription claims for antihypertensives and who have a diagnosis of hypertension during the measurement year. And then the numerator was looking at, of that total population, who is at control as of their last blood pressure reading in the measurement year.
Perfect. Thanks for providing a little more clarity there. The questions are flowing in and we love it. Keep it going, everyone. We do have a question about a little bit more boots on the ground. How do the pharmacy partners ensure patient engagement what sorts of methods were used to get patient buy-in? Always a really good question. Chris, I'm curious to get your sort of broader perspective on this one.
Yeah, great question. I would see that would come up, right? If we're going to design an intervention, how do we, what's the, what's the collaboration with the patient overall? So these networks were really built on the principle that pharmacies are in and of their communities, right? So they're front facing, they're accessible. We saw this through the pandemic with, the expansion of services and opportunities as well, but there's more touch points with patients, right? So depending on the intervention, there may be multiple touch points that are needed to be able to do that. And I think a great example of the types of programs that might have that would be social needs screenings. For some patients, this might not be the most comfortable topic, but because they trust their pharmacy and they may not know these services are available, it may need a couple times, or a development of relationship with a delivery driver, a pharmacy technician, community health worker, other personnel, non-pharmacy personnel is really, really key to that. And there's been specific investments made in these programs to ensure that continuity of care overall. Beyond that, with patient engagement, the pharmacies, know their patients very well. They utilize a variety of methods, whether it's in line with a flip the pharmacy principle would be medication synchronization. So they're seeing the patients on a regular basis, 30, 90 days, and they're doing appointment-based models to be able to pair vaccine gap closure, blood pressure reading, A1C to be able to do that. We also know pharmacies go off-site. They're able to be extenders within the community, and whether that's engaging local community centers, local departments of health, provider offices, and making them aware of their added services, they're able to see further engagement with patients overall. So engagement is one. Another important topic I'll answer real quick as well is retention. That's always something within these programs, especially if there's multiple touch points, is always a concern. But pharmacies do work in a similar fashion to either provide incentives or to provide regular checkpoints to make sure if it's a multi-step intervention that the patient is retained throughout. Thanks, Ben.
Perfect. Thanks for clarifying that. Heather, anything to add on that one, or are we good to move on?
No, I think Chris did a really great job encompassing all of that.
Yeah, I agree. And I'll grossly overstep my Q&A moderator role by saying, PQA definitely acknowledges the importance of patient engagement in these types of pharmacy pilots. Really, when we think about our pilots, we did get a decent idea, a good idea of what was happening on the ground with respect to interventions. But really, our primary focus was on the feasibility of collecting and sharing those data, as Heather spoke to really inform these draft pharmacy measure concepts. I do think it's a really rich area for further work to better understand exactly what patient engagement strategies work best in the pharmacy. That's a space that, how best to engage patients during hospital discharges or during provider simple office visits. Those areas have been studied very, very in depth, I think, as pharmacies continue to step into this increased provider role. That type of future work will be really meaningful to help guide interventions in these value-based arrangements. Okay, stepping back to my moderator role. Is there an opportunity to share, and then there's essentially some additional analyses here, maybe some more information that's beyond what's in the dissemination report linked. For example, a range of the absolute changes across participating pharmacies. I think looking at the specific NPI level, the question asker does correctly note that aggregated metrics, as you roll things up, little pieces of signal can get lost as you melt towards a population mean. So does PQA sort of plan to, are there any more analytics or data that we can release right now around the pilots?
Yeah, so we did do a number of analyses on these results, but we're really careful with what we share because we do want to maintain our partners' anonymity when it comes to these pilots and the data coming out of it. And something else important to note, these are draft measures at this time. And so, because of that, we don't want to release the individual NPI data and have conclusions be drawn on pharmacy quality based on those measure rates. Because again, these are our draft measures at this time, but we will be continuing to look at what we have and how we can disseminate additional information about the pilots that are of interest over time.
Agreed. And for the next one, just a quick question about lines of business. The question asker notes that they're assuming this was for either, I'm not sure what the second half of this is, MAPD or MCAPI plans. I'm not certain what an MCAPI plan is, but Heather, maybe you can speak to the lines of business involved in the pilots.
Yeah, so within the pilot, there was, we varied across the different lines of businesses. Medicare plans were involved, but the pilot was not strictly composed of the Medicare population.
Perfect. Thank you very much. And the last question, which I suspect Chris might have some insight on, is again a little more boots on the ground, but maybe boots on the ground on the sort of performance management side. Were the pharmacies involved in the pilots and in these resource guide development independent or chain? And with respect to independence, how much time does the sort of performance management aspect of that take? Obviously, when you think about individual independent pharmacies, there's a lot of them. And so scale, when you're dealing with these large numbers of independents, seems like it could be challenging. So Chris, want to speak to that?
Yeah, absolutely. I can talk more from our project and our resource guide specifically. I think when we're looking at this, we're primarily talking about independent pharmacy, and I could say that with almost 100% certainty of participation. There may be some others in the model, but I don't want to misspeak. So we're talking about independent community pharmacies. And when we're getting at like the time it takes and like how do you engage one of these networks to move forward overall. So there is layers to the model, specifically in what we looked at. We specifically looked at community pharmacy enhanced service network. The advantages there is there's a national model, right? It grew from North Carolina, encompasses all of these individual networks and comprises of over 3,500 pharmacies. That is an outstanding number and really is a large impact. But then when we look at these individual plans and we go to the state level, and most states have one model that would encompass this, some states have multiple, you're in the hundreds of pharmacies that you're able to move throughout. So these individuals, I mentioned they were program facilitators, or also term managing network facilitators, are the individual that would be back and forth between the leadership, the pharmacies, and are able to, they're very accessible, they're able to be connected. And, and Heather got at this a little bit, the conversations may take, a little bit of time, especially if it's going to move to a active project where, contracting would be needed. But you're typically looking at, months of meetings to lock down a program. But once the program is going, it can be very effective. It could be short term, it could be long. But my, positive experience in working with these is these networks are very hungry to engage, very eager, and they're able to move very quickly, which is a very great advantage overall with this. Ben, was that the gist of the question? Was there anything else I missed?
No, absolutely. I think that was a great one, and is a good question, right? Whenever you're dealing with lots of sort of independent small units in any type of contract situation.
Absolutely.
Yeah, absolutely. Again, great questions here. I see we have, we're almost at 10 minutes left. I know we have a few minutes of wrap up too, but want to make sure we get to all these questions. So Heather, what are the next steps as far as moving these measures forward? And when PQA envisions their use, are we talking about implementing them at the independent pharmacy or rather the individual pharmacy NPI level?
Yeah, thanks, Ben. So we are taking those measures, specifications, and the results back in-house, really reevaluating them from top to bottom to see if there are any areas of the specifications that need additional clarity. We're also thinking through, some additional testing around reliability as well. These measures, because they're draft, they still need to go through a consensus-based process. And so hopefully in the future, we'll be bringing these to our membership for an endorsement vote after they've been through our quality metrics expert panel for a more thorough review. I think to the question around, what's the intent for implementation and whether that's at the NPI level, certainly contracting can look very different in a lot of ways. We do want the ability to measure at the NPI level, assuming that, the NPI has a, sufficient denominator size, but, measurement at a network or chain level is, possible as well. I think, and we've talked about this before, and we'll certainly probably get into this in our leadership summit later this year, but, when it comes to pharmacy measures and pharmacy measure at a analytic level, we're looking at smaller denominators than at the health plan, and so we're thinking through what that means. And sometimes if you only have 2 diabetes patients, perhaps you shouldn't be engaging in a arrangement that involves a diabetes measure of some sort because you don't have enough patients. So I think we still have a lot to look out for on that, and we're really excited.
Perfect. Well, that has taken care of the Q&A, it looks like, unless anyone jumps in at the last minute. Really love the engagement from everyone. I think it speaks to sort of how hot this space is. Everyone's very interested in it. It's growing very fast, and I'm glad that both PQA and Chris's team at University of Buffalo can be a part of this transition. I do want to call, before we move forward, folks' attention just to the chat. We did hear from Kelly Brock with CPF, just noting that the CPF will make the resource guide available when the project is completed. We'll work with key stakeholders and partners to make sure that that goes out far and wide, as well as being posted on their website. So dissemination of that is a priority. PQA, is happy to amplify that signal as well. Well, with that, I believe that we're just about ready to wrap up. I'm going to ask my host here, Amanda Ryan, if we have anything else we need to cover before we dismiss our folks on the webinar here.
Yes, Ben, in fact, we do. So
Perfect.
Thank you for passing it back to me. We've got a few announcements here to share with everybody. So bringing the slides back up so that you can see that. There we go. First, I wanted to call your attention to our registration that will be opening soon for both our PQA Convenes and the 2024 PQA Leadership Summit. Both of these events are going to be taking place in Arlington, Virginia. The PQA Convenes will happen on November 7th, and it will focus on quality medication use in rare disease. And then the Leadership Summit will take place starting in the afternoon on November 7th, as well as on November 8th. And its focus will be on pharmacy measure use and value-based arrangements and quality improvement programs. So sounds familiar from the topic we just had here today. So be on the lookout for the registration information to come out soon, and we do look forward to seeing you with us in Arlington. And then our next Quality Essentials webinar is going to be on Wednesday, August the 14th. That'll be at 1 p.m. Eastern time. And our topic there is going to be medication therapy management quality measurement. And I am going to drop the link in chat right now to register. So while you're here, while you're thinking about it, we encourage you to sign up to attend that webinar, and we look forward to hosting you next month. And then finally, please save the date for our next stakeholder advisory meeting, and that's going to take place on Wednesday, October the 23rd at 1 p.m. as well. Registration information will be made available for that webinar to PQA members as we get closer to the date, and we look forward to seeing you there. And with that, I would like to thank you all for attending our quality forum today. Thank you to each of our speakers for sharing all of this great information with us, and we hope you all have a great rest of your day.